Good morning, everyone. Welcome to day 2. We have back-to-back scientific sessions to start off the morning, and then we will have a short break and return for the MCW Stuart D. Wilson Historical Lecture by Dr. Wen Shen. So a great way to start the day. And for our scientific session 2, we have moderators Dr. Judy Jin and Doug Fraker. Thank you for being with us this morning. We can invite our first presenter to the podium.
Good morning. We have a parathyroid session, fairly heavy on bone density. I'd like to ask Dr. Daniel Gomez Carrillo from UAB to come up.
Well, thank you all for having me. One of our authors is supported by an NIH T32 grant. The other authors declared no conflict of interest. As a background, thiazide diuretics are one of the several first-line treatments for hypertension. And they are approximately used by 1/3 of all hypertensive patients in the US. And hypercalcemia is a well-known side effect of these drugs. But it's also the hallmark of primary hyperparathyroidism. Because this overlap can discourage further workup, primary hyperparathyroidism may go underrecognized in this population. In that context, frame our objective to assess the rate of parathyroid hormone testing among thiazide users with hypercalcemia, the prevalence of biochemical findings consistent with primary hyperparathyroidism, and the clinical consequences of a misdiagnosis. For doing so, we performed a retrospective cohort study from 2005 to 2025 using a large multi-institutional research network called TridentX. Adults with 2 instances of hypercalcemia after 1 month of thiazide use were identified. We then quantified the rate of parathyroid hormone testing and the prevalence of primary hyperparathyroidism defined as an inappropriately elevated PTH in the setting of hypercalcemia. And then we made a comparison between treated and untreated patients with primary hyperparathyroidism using 1-to-1 propensity score match for age, sex, tobacco use, glucocorticoid use, GFR, and Charlson Comorbidity Index. Our outcomes were the incidence of fracture, osteoporosis, and nephrolithiasis. In order to focus on the relationship between sporadic primary hyperparathyroidism and thiazides, we excluded alternative causes of hypercalcemia and genetic causes of primary hyperparathyroidism. One of these exclusions that we see on the screen are, for example, malignancy disease, medications that may alter the calcium homeostasis, calcium supplementation, other non-sporadic causes of primary hyperparathyroidism, such as MEN1 and 2 syndrome, and finally, chronic kidney disease. We identified 268,700 patients with 2 instances of hypercalcemia after 1 month of thiazide use. After excluding for alternative causes, 98,554 patients were deemed at risk of primary hyperparathyroidism. Of these, just 350 patients underwent PTH assessment. Of this group that underwent PTH assessment, 21,285 patients had a PTH greater than 50, suggesting primary hyperparathyroidism, but just 850 patients of this group underwent parathyroidectomy. Here we can see some demographical characteristics and clinically relevant variables of our cohorts. After propensity score matching, most of the variables we accounted for were balanced, given the standardized mean difference less than 0.1. After propensity score matching, 805 patients were in each group. It was found that untreated patients had a significantly 70% increased risk of developing osteoporosis and a higher risk of developing fractures and nephrolithiasis. Then the time to bend analysis consolidated our findings, showing a higher hazard of developing bone disease and no significant statistical difference for nephrolithiasis and fracture incidence. So the takeaways are straightforward. When these patients are actually tested, more than half have biochemical findings consistent with primary hyperparathyroidism, and the failure to evaluate this disease in this population results in a missed opportunity to intervene and obviously avoid the long-term sequelae of primary hyperparathyroidism. Thank you very much. Happy to take any questions.
Thank you very much. This paper is open for discussion. So I will start out. So you have this. You have people that order a PTH. So one cutoff was having the elevated calciums, and then you had a certain proportion, almost 30,000, who ordered the PTH. You had a very small proportion of those underwent surgery. So someone was thinking hyperparathyroidism. Otherwise, you wouldn't order a PTH, you wouldn't screen for it. Any thoughts as to why you would order a PTH, find out they have it, and then not act on it? And the second question is, you used a cutoff of 50, and certainly we all see a lot of people that we think, especially primary care physicians that are doing the management, don't appreciate normal hormonal hyperparathyroidism. And so they see, oh, it's a normal PTH. So if you used your cutoff of 65 or whatever, have you looked at the cutoff of upper limits and normal, if it would change your data?
Well, answering your second question first, probably using multiple cutoff, maybe this might change the data considering the distribution of the PTH values across the cohort. However, I think that basically because of that and the under-recognition of normal hormonal primary parathyroidism, that's why it leads to the 4% of US dispersion being receiving surgery, so I think that will answer also your first question.
This microphone.
Hi, Surya Prangi, Boston. Great talk. I was just wondering if you've thought about sort of where we could intervene in this problem, you know, where the interventional steps could be, since you have the data in terms of what kind of automated appeal could we make to the PCPs? At which stage could we alert them, you know, so that they could refer the other 28,000 or whatever number, a very large number, because it is, I think, quite frustrating for the patients as well once they eventually make it after all the fractures and all the problems. So.
Yeah, thank you very much for your question. We are actually working on that in our institution. We are currently working on developing an alert system that may flag these patients that have multiple instances of hypercalcemia. However, we have noticed similar numbers in terms of that they are not being referred appropriately to endocrine surgeons. So I think that, it's a thing that we will definitely have to work on with the PCPs to avoid the under-recognition of primary hyperparathyroidism in this population and in a broad population of patients.
Dr. Broom.
James Broom, Nashville, Tennessee. Excellent presentation. One question, in your abstract here, it says out of the people that actually got treatment, you know, it was only 8%, which I think we know is unfortunate, but it also looks like it was almost even. You called treatment parathyroidectomy and cinacalcet, and you put in some data about people who got parathyroidectomy and what their outcomes were. Didn't know if you looked at that cinacalcet group and said they did do well, they didn't do well. My suspect would be we could prove that that was a poor choice and perhaps avoid these people being on an expensive long-term medication for no good reason.
We didn't actually do that comparison later on. I think that the treatment for primary hyperparathyroidism is surgery and not cinacalcet. That's why we avoid doing that comparison. And that's why we excluded it at the end.
Well, and it may be then a valuable point. If you have that data already pulled and looked at and you've got these people broken out, that might be an easy way to add another layer to this paper that also helps maybe steer people away from the wrong choice.
Yeah, that's true, sir.
Carrie Cunningham, Boston. Often, at least at our institution, the primary care physicians or sometimes our urologists who see patients for kidney stones, which is a common source of referral, take patients off the thiazide for a while. and see how their PTH responds prior to referring us. And I'm wondering if you collected that data in any way, shape, or form, or you have the ability to do that, to see if there was a time off of it to sort of screen people or maybe risk stratify people.
Yeah, thank you very much for your question. That's actually a limitation of our studies because with this database, we cannot capture if, for example, in a certain group of patients that the thiazide was stopped and then the calcium values normalized or what happened to the PTH. It will be hard to tell. That's certainly.
Seems like a good follow-up study for you to do at your institution. Herb.
Thank you very much.
Yeah, keep in mind, Carrie, about 70% of people who had this were in your database never had a PTH level checked. And so that may be the population where they came off their thiazide and then got better. So, other question? Thank you very much.
Thanks.
Our next presenter is Dr. Yang Luck, and his presentation is on improvement in body composition and insulin resistance after parathyroidectomy for primary hyperparathyroidism, a prospective case control study.
Thank you. Good morning. I'm Yan Lok from the University of Hong Kong, and I'm going to talk about the changes in body composition and insulin resistance after parathyroidectomy for primary hyperparathyroidism, a pilot prospective case control study. I would like to thank the AAES for giving us the opportunity to present our findings. We have no disclosures. So there has been growing evidence on the link between primary hyperparathyroidism and metabolic risk factors in recent years, and a strong correlation has been demonstrated between body composition parameters and metabolic risk. So the aim of our study is to compare body composition and insulin resistance changes among patients with primary hyperparathyroidism undergoing surgery versus non-surgical management. This was a prospective case control study involving consecutive patients diagnosed with primary hyperparathyroidism and indicated for surgery. For patients who had persistent or recurrent disease after previous parathyroid surgery with parathyroid carcinoma, multiple endocrine neoplasia, or surgically unfit patients, they were excluded from the study. Parathyroidectomy was offered to all patients, and for those that agreed and underwent parathyroidectomy, they were included in the surgery group, while for those that were pending preoperative localization studies, indecisive, or declined parathyroidectomy, they were included in the non-surgery group. Body composition analysis was performed with bioelectrical impedance analysis, while insulin resistance was measured using the homeostatic model assessment for insulin resistance, or HOMA-IR score. For the surgery group, the assessments were made before surgery, at postoperative 3 months and 6 months, while for the non-surgery group, assessments were made at baseline and at 6 months. The primary outcome was any difference in the 6-month body composition changes between the two groups, while the secondary outcome looks into the insulin resistance changes. So in total, we had 66 patients included with a mean age of 63 years old. 31 of them were included in the surgery group, while 35 in the non-surgery group. There are no significant differences in terms of the baseline comorbidities, as well as the baseline body composition parameters. So we then look at the body composition changes across time. First, within the surgery group, you can see that there is a significant increase in the fat-free mass, muscle mass, and also skeletal muscle mass at 3 months, while numerical similar findings were obtained at 6 months, but they were statistically insignificant. As for the non-surgery group, at 6-month follow-up, there was a significant increase in the body weight and also body mass index. And also, there was a significant increase in the fat percentage, which was measured with reference to the total body weight, and also an increase in the fat mass. So when we compare the two groups' 6-month body composition changes, the non-surgery group had a significantly greater change in the fat percentage, as well as a significantly greater percentage change in the fat mass. While there were no significant differences in terms of the changes in the other body composition parameters. As for insulin resistance, despite a numerical reduction in the HOMA-IR score for the surgery group at 6 months, there were no significant changes in terms of there were no significant differences in terms of the 6-month HOMA-IR changes between the two groups. So we found that the non-surgery group had a greater increase in fat proportion measured in terms of with reference to the total body weight, as well as a percentage increase in the fat mass when compared to the surgery group at 6 months. This could be related to intracellular signaling mechanisms by calcium, as studies have shown that in patients with primary hyperparathyroidism, they had a higher free intracellular calcium within the adipocytes, which suppresses lipolytic response to catecholamines. As for insulin resistance, there were no significant changes found. It is uncertain whether the disease severity of primary hyperparathyroidism may affect the metabolic outcomes, as all the patients included in our study were having classical primary hyperparathyroidism. And this served as a pilot study in assessment of the metabolic impact of surgery, so further large-scale studies would be needed. Strengths of our study included its prospective nature and also a presence of the control group, while study limitations included its small sample size, lack of 3-month data in the control group for comparison, and also limited generalizability since this study was performed within the Asian population. Other environmental factors such as dietary or activity levels may also be confounders affecting the body composition changes, which were difficult to control, and probably it should be controlled in future studies for better assessment of the impact. So to conclude, parathyroidectomy for primary hyperparathyroidism minimizes body fat gain when compared to non-surgery, and with an improvement in body composition parameters, parathyroidectomy may improve the metabolic risk in patients. Thank you.
Thank you for a great presentation, and then we're now open for discussion. We'll start on the right side.
Hi, Andrea Gillis, UAB, no disclosures. Really great study, very well presented. I noticed your mean BMI was about 24, which may be a little less relatable to the surgeons in this audience. Did you have any patients who were overweight or obese, and maybe stratifying your results that way might reveal some other differences?
Thank you for your question. Yes, indeed, I think there are some differences in the body composition between the Caucasian and Asian population. So the mean BMI is probably a bit lower in the Asian population. And we also did some subgroup analysis in the manuscript, which we looked into whether the BMI differences may actually affect the outcome of the patients. So in our subgroup analysis, we found that there's actually a more profound effect in the patients with a lower BMI of less than 25, which was actually the cutoff for obesity for Asian population. While there were similar findings found in the higher BMI group, but they were not statistically significant in our study, so probably future large-scale studies may be needed to assess the impact in these patients. Thank you.
Please.
Hi, Sarah Altman from UT Southwestern. Thank you for presenting this work. I think this is really exciting. Did you guys look at any of the symptom relief as far as whether or not some of these changes may be related to resolution of fatigue and aches and pains? Is that something that Jill looked at or will be planning on looking at for the next phase?
Thank you for your question. We didn't exactly look into the resolution of the symptoms after surgery, but definitely it's something, the way to go in the future studies, and maybe it could be related to the changes as well, so it's probably one of the confounders, and we can look into that afterwards. Yes, thank you.
Dr. Steve.
Hi, Carolyn Seib, Stanford. Really nice job and exciting, sort of promising research in this area. My question is just, you have small sample size. You said no real differences in baseline characteristics, but, that was all based on statistical comparison with small groups. Did you do anything to account for differences in the patient characteristics in your analyses? Because I think, where we start to see, we can't use causal language, obviously, because this is not a randomized controlled trial, and we don't have really any way to normalize differences between the groups. So did you do any adjusted analyses? And I just think we have to have a little bit of caution seeing a change so quickly after surgery and attributing it to surgery as opposed to differences in characteristics between the patients who chose surgery and those who didn't.
Again, thank you for your question. For our patient recruitment, we didn't do any specific stratification when we do patient recruitment, and just by the subsequent analysis of the patient demographics and the comorbidities, there were no significant differences. But I think because this is a pilot study, because currently to our knowledge, there's no definite evidence on the 6-month changes in the body composition for these patients. So we're aiming to get a pilot study on having the effect size of the changes in the body composition, which helps us in the subsequent sample size calculation for a larger scale study. And afterwards, probably in the larger scale study, more could be seen of like any differences, there could be differences in patients recruited or whether this could impact on the subsequent outcomes of the patients. Thank you.
To follow up on that question, I think another interesting thing to think about is both of your groups are patients with hyperparathyroidism. It may be interesting to have another group who does not have hyperparathyroidism as a case control group as well.
Thank you for your comments, and that's something that we can do in the next step. Thank you.
Thank you very much.
Thank you very much.
The next presentation is bone modifying agents may alter biochemical presentation and operative findings in primary hyperparathyroidism. Dr. Abigail Shamil from WashU.
Good morning, everyone. My name is Abigail Schmiel. I'm a research resident at Washington University in St. Louis, and I'll be presenting our work, Bone Modifying Agents May Alter Biochemical Presentation and Operative Findings in Primary Hyperparathyroidism. We have no relevant disclosures. In primary hyperparathyroidism, excess PTH drives osteoclast-mediated skeletal resorption, and skeletal calcium mobilization is a major contributor to the hypercalcemia we see clinically. At the same time, bone-modifying agents, including bisphosphonates and denosumab, are increasingly used to suppress osteoclast activity in patients with osteoporosis. This raises an important clinical question. If we pharmacologically reduce skeletal calcium release, are we also altering how primary hyperparathyroidism presents and potentially how we operate? At our institution, surgeons noted a possible increased rate of multi-gland disease among these patients on these therapies. So our objective was to evaluate whether bone-modifying agent exposure is associated with differences in both biochemical presentation and operative phenotype in patients undergoing parathyroidectomy for primary hyperparathyroidism. Mechanistically, elevated PTH increases Rankel signaling, driving osteoclast-mediated bone resorption and calcium release. Bone-modifying agents blunt this pathway, reducing skeletal contribution and potentially the biochemical severity of disease. This formed the physiologic basis for our hypothesis that these patients may present differently. We performed a retrospective cohort study of patients undergoing parathyroidectomy for primary hyperparathyroidism between 2019 and 2025 at a single tertiary referral center. Bone-modifying agent exposure was defined as active or prior anti-resorptive therapy. We compared patients with and without exposure with respect to preoperative calcium and PTH, bilateral neck exploration, and multi-gland disease. We performed univariate and multivariable logistic regression analyses. We identified 899 patients, of whom 21% had history of bone-modifying agent exposure. These patients were more often older, with a median age of 70, were more frequently female and white. They also had a significantly increased rate of preoperative osteoporosis and preoperative fragility fracture. Importantly, these characteristics, particularly age, are also associated with multi-gland disease and represent potential confounders. We first examined preoperative biochemical profile. Among BMA-naive patients, mean calcium was 10.9, and mean PTH was 119.7. In contrast, patients with BMA exposure had a lower mean calcium of 10.5 and lower mean PTH of 99.5. Both differences were statistically significant. While the absolute differences are modest in a disease where biochemical severity often influences localization confidence and operative planning, even small attenuation may be clinically meaningful. We next examined operative phenotype starting with bilateral neck exploration. Bilateral neck exploration occurred in 54% of BMA-exposed group, compared to 40% of the BMA-naive patients. This finding was statistically significant on unadjusted analysis. Multi-gland disease was also more common in the BMA-exposed group, 42% compared to 34% of patients without BMA exposure. That difference was also statistically significant on unadjusted analysis. At first glance, this suggests a higher prevalence of multi-gland pathology in patients with BMA exposure. However, given that these patients were older, we wanted to determine whether this finding persisted after adjustment. We then adjusted for age, sex, and osteoporosis in a multivariable logistic regression model. After adjustment, BMA exposure was no longer independently associated with multi-gland disease. The study is limited by its retrospective single-center design. We were unable to fully capture medication adherence, duration, and timing of administration relative to labs and surgery, and potential residual confounding persists despite multivariable adjustment. Finally, many patients had exposure to more than one bone-modifying agent, which limited our ability to perform subgroup analyses. In summary, bone-modifying agents are associated with an attenuated biochemical profile in primary hyperparathyroidism, but they do not independently alter glandular extent. Clinically, this means BMAs may mask biochemical severity, and reviewing pretreatment labs may be helpful when available. Finally, further studies are needed to investigate the relationships between BMAs and multi-gland disease. Thank you, and I'd like to acknowledge my co-authors and mentors for their support. I'm happy to take any questions.
This paper is open for.
Hi, Brian Utch from New York. Fantastic presentation. What an interesting phenotype. I had a question about your operative approach. Your multi-gland disease rates are relatively high. And so do you perform focused parathyroidectomy, or do all patients at your institution undergo 4-gland exploration?
We do focus focused parathyroidectomy. I think the rate of our bilateral neck exploration is between 40 and 50%. So it's pretty reflective of the cohort here. But we do focus parathyroidectomy as well.
Dr. McHenry.
Chris McHenry from Cleveland, Ohio. I enjoyed your presentation. So in your 2 groups, you found that your bone suppressing agents were not significant as the explanation for multiglandular disease. So what do you think the explanation is for the difference in multiglandular disease between your 2 groups? Is it osteoporosis? Patients with osteoporosis, are they more likely to have multiglandular disease?
Yeah, I think that's an interesting question. I think it's going to be really hard to tell. I think a lot of these patients had overlapping characteristics. That group had osteoporosis. They were older. You know, they're on these medications. They're often on a lot more medications in general. So I think there's a lot of factors at play that could be resulting in the multi-gland disease, and it may not be a single contributor. But like I said, I think age may be one thing, but also interacting with medications and things like that may be resulting in the higher rates. Thank you.
Carmen.
Nice presentation, Carmen Solorzano, Vanderbilt University. A couple of questions. When I see these patients, some of them come with much higher PTH and much lower calcium, sometimes normal calcemic. So I wanted to ask you if you saw that in your cohort with the active or prior exposure to these bone-modifying agents. And 2, what are you doing surgically? Like, overall, give me a gestalt of I end up doing a lot of subtotal parathyroidectomy in some of these patients. So just to comment, those two questions.
So for the first question, we kind of saw a spread as well, but I would say it kind of trended towards the lower PTH, or not super elevated PTH, and like a very minimally elevated calcium. But we did have some on the upper end, which I think is an interesting finding. And then in terms of the operative approach, most of the patients with multi-gland disease all got subtotals. Yeah.
Thanks.
So I have 2 follow-up related questions. So you use the term multi-gland disease. I would make a distinction between double adenoma and hyperplasia. Adenomas are mutational events and shouldn't be impacted by bone density modifying agents that may alter the calcium metabolism, whereas I don't know who and how we understand sporadic hyperplasia.
Yeah.
So were all of your multi-gland disease hyperplasia, or what proportion were double adenomas?
Yeah, so this is one of the limitations of our study, is that the multi-gland disease was defined by the surgeon in the operating room and not based on pathology. So that's one of the things we're going to look at in the future, is how these patients might differ based on their pathologic finding or their histopathology.
The second question, to follow up on Carmen's question, as at least my experience as patients get older, particularly women, the ionized calcium often is much higher than the total calcium. Your age is higher in your bone modifying group, and I would you reported total calcium. Do you have ionized calcium data?
We would have ionized calcium data, but we didn't look at it. Not all the patients had iCals pre-op. So.
Other questions? Okay, thank you very much.
Thank you.
Our next presentation is by Dr. Leah Delaney. The title of the presentation is An Informed Decision Not to Operate, Evaluating the Completeness of Workup for Patient with Primary Hyperparathyroidism.
Hi, everybody. My name's Leah Delaney. I'm a general surgery resident at Stanford. It's great to be here. We have no relevant disclosures. So as everyone in this room knows, primary hyperparathyroidism is a common endocrine disorder, one that affects more than 2 million Americans. And parathyroidectomy provides the definitive treatment, as it's been shown to mitigate progression to skeletal and kidney and organ damage. The presence of that end organ damage in part informs surgical eligibility. And so guidelines currently recommend a comprehensive workup at the time of diagnosis to assess for this end organ damage presence. Identifying patients who are likely to benefit from parathyroidectomy is essential to the optimal management. And informed treatment decisions require a full diagnostic workup at the time of diagnosis. However, currently, it's unclear whether patients who are managed without a parathyroidectomy undergo this comprehensive workup to see if they're eligible for surgery or not prior to being designated to non-operative management. An incomplete diagnostic workup can lead to underrecognition of parathyroidectomy indications and end organ damage, as well as contribute to undertreatment. So we aim to characterize evaluation patterns, as well as quantify the completeness of a guideline concordant workup among a group of patients with primary hyperparathyroidism who are undergoing non-operative management. We identified a group of patients with a biochemical diagnosis of primary hyperparathyroidism using Truveta National Electronic Health Record data, which is a nationally representative US data source that accesses health data linked with claims data as well. In order to evaluate patients who are seemingly asymptomatic, we excluded those with a kidney stone or a fracture in the year prior to diagnosis. In order to focus on patients who are undergoing non-operative management, we excluded anyone who underwent parathyroidectomy within 2 years of diagnosis. And then we evaluated which proportion of patients underwent a guideline concordant workup, and this included a 24-hour calcium, a DEXA scan, vertebral fracture assessment, as well as imaging for kidney stones. Our primary outcome was a near complete workup, which we defined as 2 or more of these 4 tests. And we also evaluated how many patients underwent a complete workup, so all four of these tests within a year before or after their diagnosis of primary hyperparathyroidism. Our cohort was made up of over 26,000 patients, and these were all asymptomatic primary hyperparathyroidism undergoing initial non-operative management. And as we would expect with primary hyperparathyroidism, our cohort was predominantly female and older adults. The majority also had mild hypercalcemia. When we looked at what the proportion of workup being completed was, we found that only 1% of our cohort underwent a complete workup, so all 4 of those tests within a year of diagnosis. 24% of our cohort underwent a near complete workup, so any 2 or more of those tests, and 43% had no workup at all within a year of diagnosis. We then performed a multivariable logistic regression evaluating the factors associated with receiving a near complete workup, so 2 or more of those tests. We found that severe hypercalcemia, an encounter with an endocrinologist, an encounter with a surgeon were all associated with increased odds of receiving 2 or more tests during their workup. And then we looked at the screening tests that were being completed. We found that the most common ones were a DEXA scan and a 24-hour urine calcium. And then among the subgroups of patients that saw a specialist, the patterns were similar. Those were still the most common tests ordered. However, patients that saw an endocrinologist or saw a surgeon were more likely to undergo these tests and underwent them at higher rates. So in conclusion, in this national cohort of patients with primary hyperparathyroidism, only 1% of patients underwent a complete guideline concordant workup, and 43% underwent no workup at all within a year of diagnosis. This raises the concern that patients who meet criteria for parathyroidectomy and who could benefit from surgery may remain untreated. And also that an incomplete evaluation could be a factor contributing to the high rates of non-operative management that we see. The study is not without limitations, the first being that we didn't require a diagnosis code for primary hyperparathyroidism, so we might be capturing underdiagnosis as well as undertreatment. And then also, although we used a large EHR database that was linked with claims data, there may have been patients who received care outside, although we think it's unlikely that this could be responsible for the large gap in testing that we see. Overall, guidelines currently aim to identify patients who could benefit from surgery. And this really, to be effective at a population level, relies on patients undergoing a complete guideline concordant workup, which, based on these results, is not happening very often. These results quantify guideline concordance, which is low, and really call for efforts to improve our evaluation of these patients, evaluation of how we're making these decisions, and how we can ensure that patients who are eligible for surgery and may benefit from it have the opportunity to undergo so. Thank you so much.
This presentation is open for discussion.
Kwang Du from San Francisco. Leah, wonderful presentation, and again highlight the importance of underdiagnosis and undertreatment in primary hyperpara. One of the things that I've seen sometime in patients' workup is that sometimes people try to cheat and get a sestamibi scan that's negative, they're done. So question I have for you is, did you look at whether or not these patients got scans done that are parathyroid related? Because we have seen that, as you know. Sometimes people don't understand that you need to make the diagnosis before you use localization study, and that has nothing to do with the diagnosis and nothing to do with your decision to operate, right? So.
Thank you, Dr. Du. No, we did not look at that yet. However, it's something we've been discussing over the last few weeks as far as incorporating that. Because I think you're right that there's sometimes can be confusion or a misordering of how things, the progression. And so we'd like to look at that moving forward. Thank you.
Dr. Stephen.
Thank you. Antonia Stephen from Boston. So first of all, great paper, really interesting topic, very relevant. As you were presenting, I was kind of thinking of a little converse thing, which is that, did you ever consider looking at the patients who were taken to surgery who may not have had the complete workup, and how that might also connect to, you know, operations that have failures for this, if that makes sense?
Thank you, Dr. Stephen. Yes, so we did examine also a cohort of patients that underwent parathyroidectomy. And we found that actually the rates and the spread of testing was very similar overall. So there was still similar proportions that went without any of those 4 tests, you know, got the 3, got the 2, and got the 1. The reason we focused on the group of patients that underwent non-operative management specifically was really to, I think when we're looking at the patients that undergo surgery, some don't need all 4 tests. They could undergo 1, be found to have osteoporosis, and then be routed for surgery. So we felt a better way to capture what the workup, you know, why these patients are not undergoing surgery would be to look at that specific cohort.
Dr. Wilhelm.
Scott Wilhelm from Cleveland, Ohio. Very nice presentation. I think a comment and a question for you. I think that your study again highlights, as we've seen in this session and we see year after year at this meeting, that based on your odds ratio, when these patients get to a specialist, an endocrinologist, a surgeon, someone who's dedicated to this disease, we do way better at screening them and we do way better at moving them along. So in light of Dr. Perengi's theme that she had for relationships and building bridges at this meeting, I think this is another opportunity that maybe the AAS as an organization has an opportunity to really reach out to the internal medicine leadership and the family medicine leadership of the United States, not like reaching out locally, but this has to be at a national level, that we get our guidelines to them and work hand in hand with them to help train the future generations to look at this disease, because we are missing this and we see it over and over, and your data highlights that, and it's beautiful. So that's the big picture. But if you bring it back down to the ceiling where we all live, how does this help you at your institution? What things have you guys done to try to help your local people get these people to you?
Thank you. It's a great comment, and thank you for the question. So when we set out to do this work, we were really trying to hone in on exactly that problem: is, you know, where's the gap? How can we bridge what's happening with these patients who we know are not undergoing surgery, and how do we get them into specialists? And so this was part of several studies that we're doing, sort of examining that period of time in between a diagnosis and the decision-making that happens. So we've been, parallel to this, also doing a qualitative work, talking to primary care providers and endocrinologists, trying to understand where that decision-making hinges, as well as patients, and then hope to bring that back and disseminate it, and with focused steps and efforts to address them.
Go to the middle, and then Dr.
Hi, Tony Bedonato, New Brunswick, New Jersey. Thank you for this great presentation and nice work. I'm not familiar with the database that you used for this study, but is there any way to look at One, whether tests were ordered and not completed, and two, other patient factors that may contribute to incomplete workup, insurance, cost, distance traveled, et cetera.
Thank you. Yeah, so the database is pretty robust. It has access to electronic health record data, so we have labs and the testing as well as linked claims data. As far as other factors, we can evaluate that. We can look at insurance data. Distance traveled is challenging because we don't have the location of the sites, but we could look at insurance data as well and see if that factors into it. It's a great idea. And then, I'm sorry, what was the first part of the question?
Whether you could see if the tests were ordered but not done.
Yeah, so in this database, we can see the results of some of the data as well. Some of it's hard to pull as like DEXA scan results and all of that, but we are able to make sure that they are completed.
Thanks.
Thank you.
Thank you, Surrey Parangi Boston. I guess I just wanted to respond to Scott. I do think that's a great idea. I think in the past, we have let the endocrinologists educate the primary cares, but I think it's time that we engage in that. And also Abby had a good idea, which is maybe we need to present some of this data at the primary care symposias, send in abstracts to their meetings as to educate sort of as to the depth of the problem, because they may not know. And the last thing I'll say is if we could get on some checklist. I mean, when I go to my PCP, I have a huge cardiac risk, but she spends 90% of the time asking me these checklist things like, do you put your seatbelt on in the back of the car? So someone has generated these checklists. If we could get somewhere into a checklist, I think that could be helpful. Just a personal comment.
It's a great idea. Thank you.
Yeah, so I just want to make a comment too. I'm not a distinguished moderator, but I'm an old moderator. My first meeting was in 1989 at the Boston meeting. I presented a gastronoma paper out of Jeff Norton's lab. So I've been doing this meeting, and we've been talking, as Scott said, over and over and over again. We see it every week. People with calciums of 11, 12 kidney stones not referred. I don't think endocrinologists are the answer, because I think it's a surgical disease. They can be obstructionists, particularly if they have negative scans. And I don't know the answer. Surrey brought this up in the first presentation. What do we do? How do we intervene? And I think the other thing is to have patience, because now with patient portals, I have a lot of patients that come in and say, I saw my calcium was so high, and I sought this out from an information page. Sorry.
Yeah, no, I mean, I think the only place I've seen that does it well is this guy, Dr. Bilizekian at Columbia, and I asked him when I went as visiting professor, when I was kindly invited down there, how do you do it? Like, how do you capture everyone? And his answer is not feasible for anyone else. But what he does is every morning he has a research coordinator who looks through every single calcium in the hospital that's been ordered, filters, and then contacts every patient. And that's how he gets it done. I'm just saying it's crazy, but that's what the system
No, I mean, we do that at Penn. Rachel's probably here somewhere. We have the nudge thing. We have it for aldosteronomas, and we also have it for parathyroid with a checklist, order these tests and so forth. Not everybody's coming through our lab and our system. It's just, it's a problem, and the risk-benefit of parathyroid surgery in experienced hands versus the benefits over the course of a lifetime are so strong. It's just a problem.
30-year challenge. Well, hopefully we'll move the needle somewhere.
Yeah, so we've had a good discussion on this, mostly because of my co-moderator, we're like still 10 minutes ahead of schedule, so I think it's a good time to take the time to discuss this. Other comments or questions? Rachel, you want to talk about the nudge? No? Okay. So our final presentation, how frequently does parathyroidectomy and adjuvant treatment lead to clinically meaningful changes in bone mineral density, a multi-institutional study presented by Dr. Drewer, both from UW, Madison, and Southwestern and Chicago.
Good morning, everyone. Thank you to the AES for this opportunity to present. My name is Nick Drew. I'm one of the current fellows at UW-Madison. Here are our disclosures. So surgery remains the only definitive cure for patients with primary hyperparathyroidism, as many of these people in the room know. There's an immense amount of literature that demonstrates that following parathyroidectomy, patients have improved bone mineral density when compared to non-operative management. However, even though there's an immense amount of literature that demonstrates that parathyroidectomy is beneficial, it doesn't tell us what proportion of those patients gain a clinically meaningful benefit following surgery. Currently, many of the studies looking at bone health following parathyroidectomy have examined the average treatment effect or the average difference between surgery and either a medication or doing nothing at all. However, there's a growing amount of literature that establishes that just because intervention is better than another on average, it doesn't mean that all patients derive that same benefit. What we get from a clinical trial or observational data is the average benefit of a treatment. However, if a small number of patients derive a large benefit, the average effect will be positive, even if many patients derive no benefit from that treatment. So while there's enough evidence to suggest that parathyroidectomy improves bone mineral density at the population level, we wanted to understand what the individual level of effect was in terms of clinically meaningful benefit for patients with primary hyperparathyroidism after parathyroidectomy. One of the things that makes it difficult to evaluate the effects of parathyroidectomy is the potential confounding effects of bisphosphonates. Patients can be exposed to bisphosphonates either preoperatively, postoperatively, and sometimes even both. So in order to ensure we corrected for any impact, we knew we had to account for bisphosphonates within our study. So we conducted a multi-institutional study at 3 different sites of patients who underwent curative parathyroidectomy for primary hyperparathyroidism. We looked at bone mineral density within 3 years, either before surgery or after surgery. We used a threshold of greater than 3.18% change in total hip bone mineral density as our outcome. This was based on a recent meta-analysis, which predicted that this would act as a threshold for global prevention of fractures in all patients. We then used a Bayesian binomial model with a weekly informative prior to analyze our results. We also conducted a pre-specified subgroup analysis of patients based on their preoperative bone status, and our follow-up ranged from about 4.4 to 8.2 years. So in order to control that confounding when it comes to bisphosphonates, our treatment groups were broken down by bisphosphonates either used preoperatively, within 1 year of surgery, or after 1 year of surgery. So all of our first groups did not use bisphosphonates preoperatively. In our first group seen here, our surgery group, none of them used bisphosphonates at all at any point. Our second group started bisphosphonates within 1 year following surgery and continued it from there. And our third group did not start bisphosphonates until at least 1 year following surgery. Our second set of groups looked at patients who took bisphosphonates preoperatively. Our first group had bisphosphonates only preoperatively. Our second started them within 1 year following surgery. And our last group started them after 1 year after surgery. Overall, we had a total of 490 patients with an average calcium around 10.7. Most of our patients were female with an average age around 67. About 1/3 of our patients took bisphosphonates preoperatively, and about half of our patients used bisphosphonates postoperatively at any time. About 92% of our patients either had osteoporosis or osteopenia prior to surgery. So overall, we found that 45.2% of our total cohort achieved a clinically meaningful benefit or recovery from parathyroidectomy based on our threshold of that 3.18% following surgery. In our patients who did not take bisphosphonates, our numbers range from about 43 to 53% of patients. And in patients who did take bisphosphonates preoperatively, our numbers range from about 36 to 47%. In our subgroup analysis looking at preoperative bone status, patients with a normal bone mineral density were about 45%, patients with osteopenia about 38%, and patients with osteoporosis about 47%. So overall, in our cohort of patients, about 45% of patients achieved a clinically meaningful result of at least 3.18% in total hip bone mineral density within 3 years after parathyroidectomy. In our study, given the wide variety of prescribing habits when it comes to bisphosphonates, it was difficult to analyze our data, and as a result, we couldn't do a direct comparison between these different groups. Therefore, we believe the next step would be consideration of a target trial with a larger sample size that allows us to address this heterogeneity in bisphosphonate use and timing of bone mineral density, or at least a larger randomized trial. I want to thank our collaborators, our other authors, and especially thanks to Dr. Ballantyne for his help with this project. Happy to take any questions.
Yes, right here.
Hi, Tony Bedonato, New Brunswick, New Jersey. Great talk. I want to know what happened to the other 50% of the patients.
That's a great question. So, you know, like I said, this study looked at the clinically meaningful benefit, so that at least that 3.18%. You know, there's certainly probably that 50% group probably had some kind of benefit for sure, but maybe they didn't reach that 3.18% in total hip bone mineral density, but certainly patients had a benefit. We didn't look at those patients in this study. I think it's also important to say that, you know, obviously bone density is not the only improvement patients can get from this surgery, and so that was part of that. We didn't look at that as well.
Yeah, I guess my question in more detail is, you know, often patients will ask me, you know, what's going to happen to my bone density, you know, and you know, we tell them some may get some improvement, you know, and I tend to tell people that it will slow the worsening of the osteoporosis. Now, did you find that was true, or am I lying?
No, I don't think you're lying. I do. I mean, I think that, you know, looking at it from a glass half full sort of, you know, piece, that, you know, hopefully about almost 50% of these patients we will be able to prevent a fracture in them for sure, absolutely guaranteed. And then those patients that don't necessarily meet that threshold that we had, certainly there's a group of those patients that, you know, we can prevent a fracture and that might not need that 3.18%.
Thank you.
Thank you.
Heather?
Heather Wachtel, University of Penn. Congratulations on this important study. I think we're all always trying to consider, are we helping people by doing this operation? I'm going to break my cardinal rule and ask you two questions. One is, are you considering looking at other measures of bone strength? Because we all know that the T-score is an incomplete capture of bone strength, because we know as parathyroid you know, mediated bone mineral density loss actually weakens the matrix of the bone. That is independent of the density. So did you think about using other measures of bone mineral density is question one. And then question two, when you did choose to look specifically at T-score, how did you choose total hip? Because one of the other very well-established things is that, you know, we anticipate more turnover in trabecular bone than calcaneal bone, but that pattern distinct to parathyroid-mediated bone mineral density loss is specific to the distal forearm. So two questions. Apologies for overloading you there.
No problem. Thanks, Dr. Wachtel. I wrote them down, so hopefully I won't have to ask you for both questions.
Excellent. Good work.
So in terms of your first question, other measures of BM bone mineral density, we did not look at those. I do think I agree with you that that would be worthwhile to take a peek and, you know, see what other things we can find from those. You know, I also think there are other measures, other confounders that play into bone mineral density, things like hormone use in women and other things that we could also sort of play into that sort of help us understand the benefit that patients may get. So I think it's a great idea to include that. As far as your second question, that total hip was based on that meta-analysis that looked at you know, a large amount of patients, and so they found that total hip BMD was the predictor in fractures for these patients. I agree with you that trabecular bone is obviously more a piece of it, but that's where it came from.
Thank you.
Scott Wilhelm,
Sorry,
Cleveland,
just to
Ohio.
clarify the question, we didn't actually use the T-score. It's an absolute bone density change, because that was the strongest predictor of fractures. So it's separate, and the reason we did it is because finally the NIH did a massive patient-level meta-analysis to figure out what prevents fractures. And that's the number we went. There are lower thresholds that have some benefit, but that's the one that basically guarantees it.
Scott?
Scott Wilhelm, Cleveland, Ohio. Very nice presentation. Did you look at what type of bisphosphonate the patients were using? Because, you know, sometimes we'll see in the orals, obviously it's patient-dependent. In the injectables, where it's maybe a 3-month formulation, it's done in a physician's office. Hopefully it's scheduled a little bit better. Did that make any difference in your outcomes?
That's a great question. So, you know, we did look at that. I think that goes to our final point around the heterogeneity of the prescribing habits. We had a lot of patients, at least from in the Wheaton UW data, that would start an oral bisphosphonate preoperatively, and then afterwards their endocrinologist is like, let's beef it up and then get an IV. So that crossover really sort of, I think, can really hinder our ability to analyze that data. So we have that. We just weren't able to sort of parse everything out and sort of look at individual levels.
So I have one final question. So 3.18 seems like be an arbitrary kind of number. Bone density measurements have been around for a long time. This is a new thing. Is this like an RFK Jr. thing, or is this, why are we coming with 3.18?
I don't believe it's an RFK Jr. thing.
I Googled it. I couldn't find out where it came from.
No, like Dr. Ballantyne said, it was based off of this large meta-analysis that the NIH conducted, looking at sort of what would prevent global fractures in all patients, and that was the number that they found that sort of guaranteed a global prevention of fractures.
Very good.
Thank you.
Thank you. So I would like to thank all the presenters. We're well under their allotted time, and so we are finishing 5 minutes early. Thank you, everybody.